figures above, the cost would be greatly outweighed by the benefit of getting patients off dialysis and improving their quality of life. 2, set up a national organ donor register. It would have to be accessible by all acute hospitals in the country, but the information could be collected via the live register or the new driving licence application form. 3, continue to promote living donors. This could be achieved by trying to reduce the time it takes to do cross-matching and workups. Encourage people to donate through incentives. For example, some states in America offer tax incentives to people who offer a kidney to a loved one. And in the last week alone, Australia announced that it would pay 3 weeks' wages to anyone who agreed to become a living donor to a loved one, up to a maximum of 3,600 Australian dollars. Maybe Ireland could consider a similar or different incentive to encourage living donors. And 4, public awareness. Public awareness is extremely important. We feel that most people, if not affected by organ donation, don't fully understand the implications and how they can help. For instance, recently and unbelievably, I was asked by a man in his mid-30s what was dialysis. This is why educating and informing is so important. Real-life stories are the greatest achiever of this. From my own part, 6 months ago, I decided to set up my own website, kidneyfailuremystory.com, with a view to raising awareness of dialysis and documenting how it has affected my life. And in a way, I wanted to give hope to other patients who had just started dialysis. The isolation at times can be immense. To date, in less than 6 months, more than 19,000 people have viewed the site. And if only a fraction of those 19,000 people decided to carry a donor card as a result, I have been successful in raising awareness. I should also note that at no stage during the website has anyone ever disagreed with soft opt-out. They've always been in favour of it. Finally, Michael, Annette and myself hope you have found the above informative and that you will appreciate our concerns regarding organ donation. We don't expect miracles, however, we would like to see an improvement to the current system, a change for a better and more positive future for all patients waiting any form of transplant, whether it be heart, lungs, liver, pancreas or kidneys. Who knows when any of us or our families may be affected by organ failure? It should be noted that you are 3 times more likely in life to need a transplant than to have your organs donated. Since the numbers awaiting transplants are growing yearly, we can't emphasise enough the real need for an immediate improvement. It's because of that reason we are in favour of soft opt-out. A change sooner rather than later. Thank you for your time.
And also to Michael and Annette, and I know you're speaking this afternoon in the audio-visual room at a meeting organised by Deputy Patrick Donovan, and I do hope that other members of the Oireachtas who are not here this morning can go to that as well, but thank you most sincerely for coming in. Our next set of speakers are from the Irish Kidney Association, Mr. Martin Doody, the chairperson, and Mr. Mark Murphy. But before I call you, just to apologise for Deputy O'Quillan, he has to go and speak in the Dáil. He's taking the other business for Sinn Féin, and Senator McSharry has to leave. He's also in the Shannon taking the other business for the Fianna Fáil party. So they send their apologies, and Deputy O'Quillan's asked me to give his support to you this morning as well. So I think is it Mark is going to go first? So Mark, you're very welcome. Thank you.
Thank you very much. My name is Mark Murphy. I'm the CEO of the Irish Kidney Association. I'll commence by giving you a brief outline of the history and the evolution of the Irish Kidney Association and treatment of kidney failure in Ireland. Dialysis as a treatment is 70 years old. It came to Ireland in 1958, and kidney transplantation started in Ireland in January 1964. In 1978, the Irish Kidney Association was founded by 3 groups of kidney patients coming together from Dublin, Cork and Galway, where hemodialysis was available. The catalyst was the need to start an awareness campaign to the public, highlighting the need for kidney donation after death. The first kidney donor cards were then produced by the IKA for the first awareness campaigns, which were 10 years after the UK health system had produced theirs. As time moved on, many more hemodialysis centres were built, some funded by the IKA and some built by the IKA. The IKA grew as the success of dialysis and transplantation grew. A new drug was discovered, cyclosporin, which is very effective in stopping the body from rejecting a new strange donated organ. This permitted far superior kidney transplantation, and liver, heart, lung and pancreas organ transplants also became possible and are now, along with kidney transplantation, normal surgery and expected by society. Currently in Ireland, out of the 3,900 patients with failed kidneys, 53%, or 2,100, are transplanted, and 47%, or 1,800 people, are on dialysis. Including all other organ transplants, there are just under 3,000 people in Ireland enjoying extended life because of organ donation resulting in transplantation. So anyone who says the Irish organ donation and transplantation system is not working is simply wrong and misinformed. What is true, and why we're here today talking to you, is that Ireland is the only country in Europe that never legislated for the organ donation and transplantation process. We did transpose the EU Directive on Quality and Safety of Organ Donation and Transplantation last August into a Department of Health statutory instrument. The houses of the Oireachtas have never willingly debated organ donation and transplantation, except for Senator Quinn's Private Members Bill number 43 in 2008. The discussion today surrounds the consent we seek from the public for deceased organ donation. For the past 49 years, the consent has been informed consent by the next of kin of the deceased. If no next of kin are available, if they cannot make up their minds in time, if there is a dispute within the family, all these situations are described as no consent, and organ donation does not proceed. If consent is refused, obviously organ donation does not proceed. But that decision is also grouped together with the other situations I've described and called no consent in all the records available to us. The dilemma of no consent has frustrated people across the globe, and particularly in Europe, where organ transplantation is advanced, and many as 10 people a day die now because of the lack of donated organs. Some jurisdictions created a law of presumed consent. The Spanish were the first to do so in 1979, and many countries chose to follow. In the course of the next 10 years, the Spanish realized creating this consent law made no significant difference to the donation rates, and there was a wide variance in their hospitals' organ donation rates. In Spain, they realized that the shortage of organ donations was not because of the public's lack of willingness. It was much more to do with the clinical practice and process and the individual skills of healthcare staff with the donating families. In 1989, the Spanish created an organization called ONT. They trained and placed organ donor coordinators into their hospitals nationally and organized the organ donation process. Spain, as a result of that, has topped and leads the world's organ donation rates ever since. They average, as has been said, 35 donors per million of population. Other countries again followed Spain's example, and many are now achieving over 30 donors per million of population as a consequence. The architect and head of ONT, Dr. Raphael Matizan, repeatedly states that changing laws on consent does not change organ donation rates. You must change clinical practice inside your hospitals to increase the rates. The practice in Spain is informed consent and is internationally recognized as being so, regardless of what the law on the statute book suggests, which is presumed consent. Again, the rest of Europe found out the exact same, and presumed consent, hard or soft versions, are now not practiced anywhere in Europe. They all use informed consent. What is worth considering is that in our strongly held view, the renaming our consent system, which would suggest presumed consent, is simply going to confuse and divide the public. The Irish people like to be asked not told to do something. Some people have no next of kin. Some are estranged from their families entirely. Some are separated and not legally so, awaiting divorce, etc. Some relatives will not be found in time. How is consent achievable for these people? Should a decision posted on a register be acceptable for organ donation to proceed in these circumstances? Could we go a little further and suggest that the recorded wishes of the deceased in their lifetime should be paramount? We do advocate, as others do, for a national organ donor registry to be used to show the next of kin the proof of the decision by the deceased in their lifetime. Should we take the decision in the register as consent if the next of kin are not available? That's food for thought. That might require written consent rather than an online registry. If so, why not consider written consent by the person as consent after their death in the circumstances that I've described as unavailable next of kin? The NHSBT, the British Blood and Transplant, the main organisation in the UK, their news press release of last week announced that the UK had increased organ donation by 50% in 5 years. They did not alter their consent system. They changed their clinical practices, as we are suggesting that we should do. In summary, creating a consent law that is different in name, but in practice will be operated exactly as best practice dictates informed consent is foolhardy and will only lead to confusion for the public unnecessarily. We have to introduce the Spanish organ donor coordinator model and the infrastructure surrounding organ donation to make real changes. We can increase our rates just like the UK have done and save and extend the lives of 50% more people as a consequence. The least important issue in the package of changes you will learn about in these presentations today is the consent issue. The infrastructure proposed will change everything for the better. Ironically, the Spanish, Croatians and other European countries have proven that this infrastructural investment returns net savings in costs against other treatments that far outweigh the initial investment. At worst, it will be cost neutral on our health system, and we will improve and extend many more lives. Thank you.
Thank you very much indeed, Mark, for your presentation, and thank you for coming in this morning. Our next speaker is Mr. Brendan Gilligan, who's the chairperson of the Irish Heart and Lung Transplant Association. Brendan, you're very welcome.
Good morning. I'm a heart recipient of 11 years. The first heart transplant took place in the Mater Hospital in September of 1985. And up until the end of December 2012, there have been 296 heart transplants in Ireland. The Irish Heart and Lung Transplant Association is a non-government funded patient group, and we welcome the opportunity to put forward our view and opinion on the proposed changes in organ donation from opt-in to opt-out, and the problems that this would create if it is changed without specific measures being in place beforehand. Ireland is a very giving, altruistic society, and our current donation rates, while it's not the highest in Europe, are still about 20 per million of population, which ranks us just above mid-table in the list of European countries. But we can and should do better. However, there is no evidence to suggest that presumed consent soft opt-out by itself will improve donor rates, and to consider it without having necessary infrastructures in place to support it would, in our view, harm the gift of life ethic, which is so important to the whole idea of organ donation. Therefore, before considering a change from opt-in to opt-out, let us look at the infrastructures that need to be in place. First, we need specialised donor coordinators in all our major hospitals. Recently, as just alluded to by my colleague Mark Murphy, the NHS released details of a 50% increase in donation figures over the last number of years, and one of the major factors in achieving that was the employment of a network of 250 specialist nurse coordinators throughout the UK system. Secondly, we need a national donor registry. We also need sufficient resources given by government to publicity campaigns across the country to inform people of the meaning of presumed consent and also to promote donor awareness. We also need proper funding for our National Organ Donation Transplant Office to allow it to function to its full potential. The importance of the infrastructures cannot be underestimated, and it will require additional resources to ensure the presumed consent soft opt-out is introduced properly. It would be wrong for you and your colleagues to legislate for a change to opt-out, thinking that it will improve organ donation and transplantation without first addressing the weaknesses and gaps that exist in our current system. We support the premise of presumed consent soft opt-out, but only if the aforementioned infrastructures are set in place beforehand. We owe it to the public and indeed to the many people who are currently awaiting a life-saving organ transplant to ensure that this is introduced with the necessary measures in place. Thank you.
Thank you very much indeed, Brendan, and thank you for your presentation. And I should have also welcomed Martin Dooley, the chairperson of the Irish Kidney Association. Martin, you're very welcome. I know you'll take part in the questions and answers later on as well. Our final speaker in this segment of the meeting is Mr. Philip Watts, who is the Chief Executive Officer of Cystic Fibrosis Ireland and also from Irish Donor Network. So, Philip, you're very welcome and thank you for your patience.
The Irish Donor Network is a network which brings together all the patient groups with a direct interest and concern about organ donation and transplantation in Ireland. And our role is to encourage and facilitate organ donation and to shape policy in relation to transplantation and donation. And a lot of our work has been done behind the scenes, if you like, over the years. But I think we have contributed a lot in terms of a positive atmosphere towards organ donation in Ireland. I think at the outset, I think it's important to say there's a division of opinion amongst us in relation to the question of soft opt-out. And most of the groups in our network are in favour of moving to that process. But it's just to say that we respectively disagree and gently disagree with our colleagues in the Irish Kidney Association, and to say there's a huge amount that we do agree on, but on this issue we don't. But just to reflect that the other groups who are in favour of moving to soft-out position includes the Alpha One Foundation, who are represented here in the gallery by Catherine, by the Cystic Fibrosis Ireland, who I represent, the Irish Heart and Lung Transplant Association, who Brendan represents, and the Irish Lung Fibrosis Association, which is also represented in the gallery today. We are in favour, as you say, of moving to a soft out position, and we understand that is the position that will be presented by the government. We do think that all the government have said on this issue to date is 3 lines in the government, the programme for national recovery 2011 to 2016. So I think there is an onus on the Minister to now set out in a bit more detail about what exactly they mean by shifting to an opt-out position. And to explain what a soft-out position is as well. So I think that needs to be done sooner rather than later. Under no circumstances would the groups that we represent in this submission support a hard opt-out approach whereby next of kin would not be consulted. Next of kin should always be consulted in terms of organ donation. And I think this is the big change between now and 2009, when this issue was considered before, where basically a hard opt-out position was being suggested by the government. We would also say that, and we agree with the Irish Kidney Association on this, that those countries that actually say they're operating a hard opt-out system whereby they say they don't consult with next of kin, that actually doesn't work in practice, and Austria is a key place in point. I think the IDN want to acknowledge the fantastic people who are involved in transplantation and coordination here, and Phyllis Cunningham, who we've worked with for many years, and I think is representative of the fantastic standard of transplant coordinators, surgeons and teams involved in procurement. And we would contend that without that dedication and skill, often working far beyond what they are called to do, we would feel that without that support, the transplant and donation rates would fall considerably. So we would say, yes, we do support a move to soft opt-out, but we totally agree with what Brendan is saying. It has to be accompanied by a measure of essential measures. The last thing that we want to do is to move towards a soft opt-out position, and then come back a year's time and say there's no difference in the organ donation or transplant rates. The infrastructure for transplantation and organ donation has to be improved. And you've heard a number of people, including patient representatives, saying the key issue around that is the appointment of a network of donor coordinators. These would be assigned to the major hospitals with ICU units, and would basically mean that there would be medical and nursing personnel who would work to ensure that the organ donation and transplant process goes smoothly, including protecting the interests and welfares of families who choose to donate organs in very difficult circumstances. I think what's also very important is we have, believe it or not, a national organ donation and transplant office, and there's fantastic work going on there by Professor Jim Egan, who's leading it, but he has no resources. He does this on top of his day job as the coordinator of the lung transplant programme in the Mater Hospital. He has firstly no secretarial support. You know, if we're serious about the coordination of donation and transplantation, there needs to be adequate resources given to his office. Also, the issue of if you're going to have an opt-out system, you have to have a system of allowing people to opt out. And I'm worried that I've heard within the Department of Health them saying, oh, we won't develop a national organ donor registry. Well, how are people going to opt out if you don't have a national organ donor registry? You simply need to put it up on a website and allow people to indicate what is their preference, opt in, opt out. And also give them a menu of organs that they want to donate. You know, some people might be happy of donating their kidneys, but mightn't be happy to donate their lungs. So to give a choice in a menu for people to donate is really, really important as well. We'd also say, I think, from a lung transplant perspective, and Catherine O'Connor, I know, would say this, and I know Brendan as well, there needs to be specific measures to improve the rate of heart and lung transplantation in Ireland. The replacement of Freddie Wood, the very fine surgeon in the Mater Hospital, is absolutely top of the priority there. But there is an inadequate number of rooms for surgery, preparation and recovery in the Mater. We need 7 rooms to facilitate the transplant programme. So again, soft opt-out will make a difference based on other experience, but not without these specific measures. So yes to soft opt-out, but only as part of a package of measures. Soft opt-out cannot be introduced on the cheap. Thank you very much.
Thank you very much indeed, and thank you for your presentation. And could I also acknowledge in the public gallery Nicola Cassidy from the Irish Lung Fibrosis Association, Lorna Murphy from the Mater Hospital Transplant Nurse, Catherine O'Connor of Irish Donor Network, and Mary O'Connor of the Irish Donor Network also, and Patricia May. You're all very welcome to this morning's gathering here. Okay, Deputy Kelleher is going to lead for Fianna Fáil. Deputy Kelleher.
Thanks very much, Chair. Just to welcome everybody here today. I suppose I found it certainly informative and inspiring in some cases. I often thought myself being quite truthful when you would read about a living organ donor, you know, how I would respond myself if my brother looked me in the eye and said, look, Bill, you know, it's life or death for me. How I would respond to something that I question, you know. But so I do really admire those people that, you know, have done this, and it certainly is something that you know, I think a lot of us probably would have difficulty in making that judgment call ourselves on a personal level. But on the broader issue, certainly, look, I would be very supportive of the soft opt-out option. And I have often wondered, because actually Dr. Patrick Hennessy, some people may have known Dr. Paddy Hennessy, he was very involved in the earlier years, both as an advocate and also as a recipient of a kidney from Cork. And I knew him very, very well and visited him a number of times. But certainly when you look at the fact that we only have 20 per million, it is low. There's no point in us saying otherwise. And I've often asked the question, because I wouldn't have the knowledge, the intimate knowledge of the infrastructure that's required But I've also wondered, is it a cultural thing? Is it a religious thing sometimes? Or is there some reason as to why we aren't more proactive in donating? And I know that we're quite an altruistic nation in many ways, but is there some reasons behind that as to why we aren't, up in the top echelons of donation? Or is it simply the fact that we don't have a proper infrastructure in place? Do we not have the number of donor coordinators in the trauma hospitals and A&E hospitals throughout the country, or is there other reasons? And I certainly think that, look, in the context of and legislation very often, it doesn't necessarily change the public's mind, but it obligates governments to do things about the legislation they've passed, which would mean putting in place infrastructure in hospitals to encourage and allow organ donation. And I suppose there's two patients in this. There's the patient that's giving and there's the patient that's receiving. And I would hope that in the context of organ donor coordinators being placed in hospitals, there would be a very strong understanding and training element to these people. Because, I mean, they will be dealing with people who are, making decisions about whether maybe a life support machine is being turned on or turned off, I should say. And there's a lot of, strong emotions at that particular time in a family. And I actually met a family, they sent me some information one time about the fact that their young child was involved in a car accident and subsequently died. But they regretted afterwards that they didn't make the decisions in the context of organ donation. And they were very, very emotional about it, because at the time their only focus was on their son. And they never looked at beyond that. And it was some time later they were very much regretted the fact that they didn't donate his organs. So I do believe that whatever decision we come to in the context of legislation, the presumed consent, soft opt-out, the one thing anyway, in all areas is the family will be consulted. Whether it is a hard opt-out or a soft opt-out or whatever, the family seems to be always consulted in every case anyway. So the infrastructure will have to be put in place for that purpose. But I do think that, when you listen to Joe and Shane and Noreen and others, it just goes to show the wonderful gift that it is. And we should be, as a committee, I think, Chair, very often we talk about policy and administration, but I think on this occasion we certainly should become champions of promoting the concept of organ donation, aside from the legislation that will come to us as well, that we would advocate very strongly, and that we would give people a platform to expand on their views as to how we can develop organ donation. Just on technicalities, and I suppose at the end of the day, there is life and death, but behind that we just need to have proper administration. And also with the advances in technology and medical technologies and immunosuppressants, and also the fact that, North-South relations, certainly we should be looking at a very strong island-based transplant system. I know that we're looking at it in the context of committee with rare diseases, but also in the context of transplantation. And I also believe that, we should sort of work closely with the UK as well across the water in that context. I know that there is strong cooperation between the various hospitals, but that we would also be able to set up some sort of infrastructure that will allow us to become more climb up the ladder of organ donation, but also that there will be a strong international sort of coordinating body. And I know that the EU is working on that as well, but I do think that we should look as a nation, when you see, when you're inspired by Joe and others and that have actually given life, I just find that actually quite emotional even talking about it, being truthful. And I'm squeamish at the best of times, I don't like going to hospitals and and when my wife was having children, I was well down the corridor, I can assure you. But so I certainly opted out, and that's my responsibilities there.
It's metrosexuals in Fianna Fáil.
But I do just want to say that I do really find it just incredible that people can do that. I'm not just saying that because people are here, but I have genuinely sat and, after reading the Examiner about a family in White's Cross and Kilcully and Cork as well, yourselves, what would I do? So I should look on and thank everybody. Now, can I just say one thing? I mean, while we are, and there is varying views on it, I think the important issue that whether there's varying views or not, that the varying views don't damage the actual, approach that we're all trying to get to. So I think while we can have varying views and discussions on it, that it doesn't become a divisive issue in the broader context of how we encourage more people to give life. So thanks, Chair, and thanks, everybody.
Thank you. No, I'm gonna,
Sorry.
I'll bring it back. I want to bring in next Deputy Sandra McClellan and to welcome her to her first outing as the Sinn Féin lead spokesperson. Deputy McClellan, you're very welcome. Sandra's a new member of our committee and she's making a good contribution to join us. You're very welcome.
Thanks very much. Firstly, I'd like to take this opportunity to welcome you here today, and your presentations have been very informative and actually quite emotional for those that have had recent transplants. Deputy O'Quailon, he was to take lead here today, but he had to go to the Dáil chamber to do leaders' questions. But he was anxious to hear your contribution this morning, and he wants it put on the Dáil record that how compelling that your cases are. I support the opt-out position. I believe the family discussion on the issue is key to any successful scheme. It is important that people who are in favour of donating their organs tell their next of kin. So if there is a tragic accident, the onus is less on the family to make the decision to donate the organ. I would also like to see specialist transplant coordinators based in every hospital trauma unit that are trained in grief counselling. This model was introduced in Spain. It led to a large increase in the number of families who consented to donate organs of a loved one. It is important that we look at introducing a system that will maximise the number of organs available. I think also, I take your point that it's very important that we have a national organ donor register. That ongoing public awareness and education is very important to promote donor awareness. And I'm just wondering what type of campaigns that you plan moving forward, and you plan on going into the schools, because I think it's a lack of awareness sometimes, and if you start in schools, they grow up with it, and then, you know, the next generation, it's second nature to them. So, but just just to say as well that I found your real life experience here this morning very compelling.
Thank you, Deputy. Our next speaker is Senator Jillian van Turnhout. Senator van Turnhout.
Thank you very much, and again, just to echo the previous speakers, thank you all very much. I'm quite new to this issue about organ donation. I did live in Belgium for about 3 years at the beginning of the 90s, which was a few years after it had come in, so it was still quite a hot topic there, and it was something that I agreed with at that time, and my gut tells me I agree. But I just want to maybe tease out one or two issues. My understanding is 24 of the 27 EU member states all have some sort of presumed consent or opt-out system in place. But if I try and look at those who are not for the model of presumed consent, which is, as I said, it's my gut feeling, but I still want to be sure that it is the right approach. There are people who say that after Belgium brought it in '86, they had a significant awareness-raising campaign, and perhaps you could attribute the rise in organ donations to the awareness-raising campaign rather than the legislative changes. And if you look, for example, people would say that the US has one of the best rates of organ donations, but they don't have a presumed consent. And Noreen, you mentioned about the tax incentives in one of the states. And certainly in the US, it seems they have, I think it's called a presumptive approach, so that families are approached with the presumption that they will agree. And I just would like to tease out a little bit more, because you've all said presumed consent, except with the exception of the Irish Kidney Association, but then the package of essential measures, and between you know, those measures, there's been a coherence on the measures that need to be brought in. So I suppose my question is, like, if the measures were all brought in, why do we need the presumed consent? What difference will that make? What's the additional piece that would make? And that's what I'm just trying to tease through my head. I found it really informative. I'm absolutely convinced that we need legislation. I hadn't realised that we had an absence of legislation in Ireland. We only have the statutory instrument to bring in the European directive. But I'm just trying to tease out between the presumed consent and a presumptive approach. Why we would opt, because there is something in that Irish people don't like being told that they have to do something. So, and it is a very emotive time for any families. So I'm just conscious that we would get this right. Thank you.
And I'll take the other members of the committee now at this stage. In fairness to them, here, Senator Burke, Deputy Conway, Deputy Mitchell O'Connor, and Deputy Doherty. so that we can go back to the witnesses then.
Just thank everyone for coming along here today. I think the presentations were very comprehensive, and well done to everyone for coming here. I suppose, could I start in just saying that I was recently speaking to a medical consultant who was involved in theatre, and they were looking after their own patient, and there were 5 hours inside an operating theatre trying to get someone through a very difficult situation, and I thought they had done a great job to find in the theatre next door to them there were a team of doctors down from Dublin doing an organ harvesting, where a young girl unfortunately had a tragic accident and the family decided to donate the organs. And the actual whole coordination that was going on there, they were extremely impressed by. And in that case, I think there was, as a result of that, there was a liver transplant, pancreas and kidney transplant directly out of the family deciding to donate the organs. And it was interesting, they were finished up, they were already 3 or 4 hours in theatre doing organ harvesting, and they advised the consultant that I was speaking to that they were flying back to Dublin with all of the recipients already on the way to Dublin. So by the time they get back, the recipients would be there as well, and they were continuing on in after midnight to do the transplants. And I suppose that's a huge idea of the commitment of people who are involved in this whole transplant area, the medical teams, nursing teams, and all the people involved. And I think we should give credit to the amount of work that they're doing, that we don't, I suppose, you know, when we look at the health service, we're very good at, I suppose, identifying the deficiencies, but also I think it's important that we give recognition to the work that is being done there. I suppose one of the issues that I have, and I suppose I have an issue, and it's an earlier issue I raised this morning in relation to the HSE, and the question I have in relation to the HSE is there any one person currently in the HSE in charge of this whole area, or is it a situation that every hospital is acting independently? Because, you know, when we're talking about coordinators in hospitals, I suppose the important thing first is, should we have one person answerable within the HE as a start, and then working from there. And I do agree with you that, for instance, in the case I was speaking to, it was the consultants, in fact, in the hospital who had advised the parents that the person wasn't going to come through, and it was the consultants who, but the family had no one else to fall back on for assistance in the hospital. And I think the idea of appointing coordinators is so important. But I think the question I need to ask is about, within the HSE itself, is there a national coordinator or any one person responsible for doing this? So that's number one. And then coordination between the HSE and the voluntary hospitals. Is there a mechanism in place where that coordination is going on? The second issue is in relation to across Europe. You know, with the cross-border healthcare directive is passed since February 2011, and it has to be implemented now. And do you see far more coordination between health services in Europe, and particularly between the UK and Ireland, in relation to this whole area? You know, that each country up to this has been working very much kind of as individuals, whereas, you know, there's more and more specialisation. Could we develop a far more comprehensive service by more coordination between member states? I'm just wondering if we're looking at that. But I think the key issue here, which you've highlighted, is the whole issue of coordinators within the hospitals, and I think that's primary in relation to the soft, you know, the whole changeable consent. I suppose, coming from a legal background, I know the difficulties that arise in dealing with the administration of the states. So, you know, it's always a difficult time for families, and I think, you know, I certainly am in favour of changing the law in this area, because I think the presumed consent, I think, is a better option at this stage, and I think it's something that I think we should be working towards. It's one that we need to use, and I agree with you, a huge public information process as well, and I think we all have a part to play in that. But you know, we worked it previously in relation to road safety. This is one area which we should be giving priority from the point of view of national coordination and a national campaign on as well. So again, thanks very much for your contributions here this morning.
Thank you. And last, Deputy Ciara Conway.
Margaret, and just to thank all the people who made their presentations this morning and their contributions, and particularly to single out the people who shared the very personal stories and their journeys in relation to organ donation, because for me I think that's the nub of the issue. You know, what if it was my sister or my brother or my daughter? And I actually have experience of it in that my uncle was a recipient of a kidney just 2 years ago from another family member, and I've seen the life-changing impact that's had on not just him but on all of us, in terms of our appreciation of him first and foremost, but just how selfless a thing it is to be able to do that. And I think, you know, it's a thing that Deputy Kelleher speaks about. You know, what if we were faced with that, what kind of a choice we would make? So just to commend you, I know it's not an easy thing to do, and to thank you very much for it. I think, you know, over the last number of years, there's been a lot of talk about organ donation, kind of particularly around the awareness weeks and the campaigns that mount around those times. But I think, you know, in the last number of months, the whole conversation has changed in terms of the opt-out model. And I think it's something that we really do need to think about. And it's something that I would support. Of course, the soft opt-out model being what I'm talking about. But in my preparation for today, and in general discussing it at home with family members and with friends, something that came to my knowledge that I wasn't aware of before, and I just wonder maybe somebody might be able to shine a bit of light on it, is that gay people are not allowed to be organ donors. And I just think that when we have such, you know, huge testing and tissue matching that goes on in the Mater Hospital, why is it that my friend who may happen to be gay can't carry a donor card? And I think that is, you know, and if that's not true, I think it needs to be expelled, because that is something that I was confronted with in the run-up to today's, you know, and I think on the back of the very insightful weekend that we had in relation to marriage equality and the kinds of steps we're taking as a society.
As a gay person, I have my e-donor card here, so...
I know, but I think it's... But I'm just saying, Jerry, as you know,
right.
just, you know, just to put it out there, that's the information that is out there. And I think, you know, now is a time that we really need, you know, to talk about these things and to set the record straight. So
Final follow up on that, because that's, I mean, I'm carrying this for a long time, and if that's the case, then I'm...
Because I know which is, I think, from a series of questions that have been submitted that they're not allowed to be blood donors. Yeah.
Okay, thank you, Deputy Conway. Deputy Mary Mitchell-O'Connor.
Thanks very much. And first of all, can I thank very much all of your presentations, and to Joe, well done on being a living donor. And Christine, I thought something that you said that struck me. You said it was the ultimate gift that you got. And Noreen, you said, my life is now my own. And again, I think it goes back to what Deputy Conway said. We have to measure it, you know, in our own lives. And you talked, and I have 2 boys, and, you know, I'd want, if they needed a donor, I'd want them to be able to get a kidney transplant or whatever. And sure, as a mother, I know I would think maybe twice about donating their organs. But I do think that if we bring in this, I think it'll kind of change the ethos. It'll be out there to discuss in the family home. You know, and there is 3 times more likely that you'd need an organ than that you'd need an organ rather than that you'd donate an organ. And I'd like to ask, and I just kind of see Mr. Murphy. Mr. Murphy, you know, in one way, and maybe I'm reading it wrong, what you're kind of saying to me is that the status quo is okay. What you're saying, yeah, well, okay. So what I want to know is, and you're the CEO of the Irish Kidney Association, like, if I'd have to look at it, and if I was a person on dialysis, I don't know if I'd be that happy. I think you said that there are 1,800 people on dialysis, and you said there's 3,000 living people, you know, enjoying new organs. And I'm aware of a person from Washford that travels up. He's in UCD. He has great difficulty. You know, he goes into hospital that's organised 3 days a week. If he wants to go home at weekends to his family, like any student, that all has to be organised with Washford General Hospital. Not to mind if he wants to go on holidays. It's another huge issue. And, you know, he's only a young student, and he wants a life ahead of him. And I just find it hard that you be sitting there as the CEO saying, you know what, status quo is fine. Now, I'm going to give you plenty of time to answer that. I just find it hard, and I know you did say, you said, my notes are all over the place. You said, yes, that we need to have a network in the hospitals coordinating, and I understand that. But my understanding is that the people that want the soft option, or the soft option, they also want that. You know, and they also, what's really important is that the family will have a say. And you said, oh, well, you gave examples that maybe people are living alone or maybe people are separated and all that. But by having this conversation now, it's giving the Irish people a time before, please God, that they're ill or on their deathbed for that decision to be made. Because now here we are discussing, you know, this new ethos, this new kind of ethical ethical atmosphere where people will discuss about the soft option. Thank you.
Thank you. Deputy Doherty.
Thanks. Good morning, and thank you very much for coming in this morning. And I apologise for my lateness this morning. I had another appointment first. Can I say I have huge admiration for those people, particularly people like yourself, Joe, and the example that you've set is second to none. For those people who give of themselves to those who are in desperate need to receive of it. And thank you for your presentations this morning. I'm in favour of what's collectively looked for, which is the presumed soft option or soft opt-out option. Before today, I did just a quick run around of my own family, my husband's brothers and sisters and my own, just to see, you know, how many of us had organ donor cards, how many of us didn't, what were the reasons for it. And just under 40% of our family members have organ donor cards, which is good, and I'm one of them, but I can't take the credit for actually going out and getting it myself. The only reason I have it is because my husband brought home the form years ago and we got it at that basis. But of all of the members of our family that don't have them, it's not because they don't want to or wouldn't want to, it's just that they haven't gotten around to it or life is busy or whatever. So if we just even took that as a small yardstick, that I think that the vast majority of people in Ireland don't have, you know, exceptional reasons as to why they don't want or wouldn't do it, they just haven't gotten around to it. And I think this, the presumed consent is very, very worthwhile, and I think it's incumbent, but I suppose on all of us to get behind it and to make sure that it does happen, that we're not just talking about it again here in a number of years. Can I ask just one qualifying question? And I think it goes back to something that Colm said. Because this probably isn't owned by anybody within the Department of Health or the HSE, I couldn't find any definitive answer as to how much the ICT infrastructure will actually cost if we were to put it in place, and how much the network coordinators within all of the hospitals would actually cost, and how we could actually fit it into the budgets. If it isn't being measured, it's certainly not been, you know, even considered to be put into future budgets in the future. Do any of your organisations have that figure so that we can then take it back and start having real substantive talks about how we can ensure that it's put into budgets in the coming years? Thank you.
Thank you. And finally, Deputy Paddy Coffey.
Yes, thank you, Chairman. And first of all, I want to thank you, Chairman. I'm not a member of this committee, but I've been listening with interest to all of the contributions from all members. And indeed, I want to thank you and all of the work that you are doing in the whole area of organ donation. I just wanted to give a perspective as a deputy who comes from a donor family. It's the first time I've spoken about it on the public record. But almost 24 years ago, I tragically lost a sister through a brain hemorrhage, my nearest sibling. And we as a family sat down at that time and we spoke about organ donation. It's something that just suddenly appears at a very tragic moment in the family's life, and we didn't have much time to think. But we sat down and we decided that she would donate. And I have to say, almost 24 years later, it is one of the most fulfilling things that as a family we all did. It's something we're very proud of. And it went a lot of steps further to that. She donated 2 kidneys to 2 different individuals, one a young man her same age, another man quite a bit older. And I have to say, both of those men are now very close friends of our family. They come and visit us, we come and speak openly about it, and we just gave them a whole new life. And I just want to say that I would be so much in favour of any, I suppose, proposal that would encourage donation in any way. And, you know, I'm listening with carefully to the presumed consent and all of that, and I think it is something we should consider, you know, and if people wish to opt out, then let them do so. But organ donation is just, and as you all know, is just such a valuable gift that we all have and can all give. And I just wanted to put that on the public record. Thank you, Chairman.
Deputy. Okay, we'll start with Mr. Murphy this time, and then we'll move back around again.
Okay. I have a number of questions to answer, and I think there's some for Phyllis, clearly should answer instead of me. But if I can go directly to Mary O'Connor, indeed, I want to clarify, you said I was complacent as such. I'm saying the consent issue...
We'll let Mr. Murphy reply, thanks.
Yeah, I'm being very clear that the consent issue is the least important issue here. The infrastructure is what needs to change. The reason I'm saying the consent issue is the least important, because it's really only a renaming of the same thing. No one is suggesting that the practice in the manner consent is conducted in a hospital changes. So why change the name of it to the public? The family are always contacted. My point was, if you don't have, if consent isn't achievable, are there some other ways we should consider? So renaming what is already in practice, which is informed consent, and calling it something else, I'm saying is maybe not clever. I don't see how it will affect the public other than divide the public. There's already been 50,000, or a poll, nothing to do with us, 5,000 people, 46% did not want informed consent, 47% did want presumed consent, and 8% didn't have an opinion. But that was 5,000 people clearly divided. 90% of the public, as far as I'm concerned, are willing organ donors. And let's not use the word presumed consent, because everyone's trying to get off it, and you can't. If you're saying soft informed consent, the word presumed consent pops out. That presumption of consent to the public is what they hear. They don't understand soft in, soft out. They hear presumed consent. That is the word, that is the emotion that creates division in the public, and that's the one I don't want to see anything to do with, if you mind me saying. Soft out doesn't work, soft opt-out, because it immediately gets converted, as it did by you all, to presumed consent. And that is what I want to know.
Sorry, Deputy, can the language we use in that context help assist in that?
You're trying to change the English language by trying to do that.
Okay, if I could take, if I could, and I have a very open mind of this now, right? If you were to take your hypothesis to its natural conclusion,
yeah,
you're saying that because of confusion of terminology and of an unwillingness perhaps to embrace the need for everybody to buy into this, that we should hold the status quo. Am I wrong in that?
No, the whole trick is in the donor coordination.
Yes. Okay.
That's what I'm saying.
Okay.
It's not in what you call the consent.
Okay.
Yeah.
Phyllis, do you want to come in?
Well, I suppose I would like to say it's a whole trick. I think there's an awful lot involved here. I mean, I suppose before we do anything, I mean, everything is important. We need public awareness. We need families. I think it's so important that families have made the decision in normal times. We can discuss this, because it is very, very difficult for people to make that decision. People are wonderful and they do make that decision. And yes, coordination is very, very important, but lots of things are important. And I think families have declined donation, because we don't like to use the word refuse donation, but families have declined because maybe they didn't know what their loved one wanted to do in life. And people, yes, have regretted that they weren't able to make that decision. So I think the opt-out, where we're presuming, because a lot of people want to be, and like that, I spoke to my family, even though I'm in this area for a long, long time, and it's just when you do ask them, you know, but I want to be a donor. But like, they have never gone out to get a card, and even when my kids, it's not something you want to sort of bring up. But I think if we know that it's something people didn't want to do, then I think, and that they're going to record in that way, that it would be...
Consider the emotion in the immediate after someone dying in terms of families in declining. Have we a body of evidence that suggests why that is the case?
We don't, and I think what we really need to do, firstly, is we need ongoing audit. We need to look at, are there donors being lost? You know, are there being ones that aren't being identified? So I think we need to have ongoing audit to see, well, what areas we have to improve on or develop on. We do have actually a National Transplant Office set up with the HSE, a National Organ Donation and Transplant Office, and Professor Jim Meakin is the clinical lead of that office.
He'll be there next week, by the way.
And he'll be next week, and many members of us are part of that. And there is a submission going into the department for all of these things, increase staffing, increasing public awareness. But I think really a key part of the whole thing is public awareness. Things like the Road Safety Authority, you know, we need to invest money in national campaigns promoting organ donation and telling about the benefits. And absolutely, gays are not excluded as organ donors. That are absolutely.
Commissioner, this we have my app.
That's not.
Brendan.
Your app is safe.
Thank you. Good.
No, I concur entirely with what Phyllis has said. I think the whole key to all of this is public awareness. And I think, you know, from the legislation point of view, I think, you know, the government are going to have to put some resources in here if they're really serious about what they're about to do. I think, you know, resources are the key here. And to even attempt to change any wording or anything without the proper measures in place first is where the problem lies. We've got to be really sure about having the measures in place before we do anything else.
Okay, thank you. Mark, you want to come in? Sorry.
Yeah, I'd just like to say, you know, I've had two kidney transplants and a pancreas transplant, and I most certainly would not be here talking to you today without the altruism of my donor family and the skill of the wonderful people in Beaumont Hospital. So I don't like, you know, anybody to think I'm in favour of the status quo, because I'm not. We need to change, as Phyllis and Brendan and Mark have said, we need to change the public perception, as in get out there with a fully financed public awareness campaign, and the Irish people will respond. And I think the register is a must for this. I think if people are asked to put their name in a register, they will. And I think it's a very strong endorsement, you know, when you go to a donor family and you can show them, right, it's not just the case that your loved one didn't opt out, or did opt out, or whatever. It's a case that they actively took the time to go and put their name on a register, which is a very, very strong argument. And basically, that is where I think our resources should be going, and not in changing a name.
Philip. Joe, Christine and Norina, Michael, Annette.
Just in relation to what's happened in the UK at the minute, which I think is helpful, is that there's been a fantastic increase in organ donation and transplant rates over the last year. But it's interesting, the British Medical Association just issued a press release, I think it was 2 days ago, to say that it's because of these infrastructure changes that the things have taken place. But they say that if we move to soft out position, we'll do even better. You know, so it's part of the package is absolutely crucial. I totally agree with Deputy Keller. The tone of the debate is really, really important, and I think we respect the right to differ from the Irish Kidney Association, but I think the tone of the debate is crucial in terms of keeping the public on board. I think the costings issues is absolutely vital, even in these very, very difficult economic times and the strain that our health system is under. We think that things need to be costed out. We need to cost out the cost of the donor coordinators, the cost of the website. But if these things are not put in place, there's a danger that this move could be botched. So the Minister has to take on the message. He cannot introduce soft opt-out without the rest of the package of measures. And likewise, just on a personal level, just to thank too the patient representatives, individual patient representatives, and Joe Brawley as well, because I think he's his personal campaign, never mind what he did at a personal level, which was exceptional, but I think it's really brought this whole issue into the public domain, and I just want to acknowledge that as well. I think it's very, very important.
Thank you. Joe?
One of the important things about the North, Senator Van Turnhout, I just cannot believe you're called Senator Van Turnhout. It's just a perfect name for a politician. I mean, it is. You couldn't make it up.
No bombing doesn't work in the committee.
Well, no. Listen.
She's a pretty perfect person, in fairness.
One,
We're good neighbours in our floor. There's always chocolate in our office.
yeah.
Sorry.
One of the important things that was agreed, we did a lot of work. You know, I had a very sort of privileged access to the First Minister and the Deputy First Minister and the Health Minister. So we did a lot of work with all the parties. I say we, look, I'm a part-timer, I want to emphasise that. And one of the things that was agreed was that, you know, or it just turns out that there is unanimity in the North on the soft opt-out. You know, so all the stakeholders, all the patient groups, you know, the clinical leads, everyone's in favour of that. And I'll come back to that in a moment. But one of the things that we agreed was, with all the parties, that it was extremely important that no misinformation be peddled about it, and that the message be given very clearly to the public that this system is based on family consent. The new system that's proposed is based on family consent, and that will be a written, informed consent. Okay. The issue about America